There we go.
Okay, there you go. Do you see my slideshow now?
Yes.
All right, very good. Well, at any point, if you can't hear me, let me know. I do have a new microphone here, so hopefully it works fine. But thank you all again very much for having me and for this opportunity to talk to you. And we had talked a little bit about, what may be of interest. And I know you all throughout the year and years have the opportunity to hear about many different lung diseases. And I have spoken with your group before, although I will say it's been a very long time, I think, since I did. So thank you for having me back again. But I thought maybe this would be a opportunity to hear about something a little bit unique. Obviously, we've all been inundated with COVID and coronavirus discussions and media. I thought this opportunity to discuss my experience in New York City might be of interest to some folks, and we can kind of use that as a launching pad to talk about a couple other related topics as well. So just a little background. As the coronavirus began exploding in New York City back in the early spring, it didn't take long, as you know, for New York City to become completely overwhelmed. It was pretty staggering, the amount of cases they were experiencing, both in their hospitals and in their intensive care units specifically. So we started getting a lot of emails and basically calls for help from a lot of our professional societies. So the American College of Chest Physicians, American Thoracic Society, Society of Critical Care Medicine in the state of New York, all started sending messages saying, we need help, we need volunteers. And obviously this was tricky for a lot of people. So I had an interest in doing this initially, but we weren't sure how things were going to go in Virginia at that point. So the last thing I wanted to do was to leave Virginia and go to New York City and then have a surge happen in Virginia and leave my colleagues high and dry with, one man down, or to come back from New York and have to quarantine, for 2 weeks and take myself out of the workforce. So I kind of waited to make sure things in Virginia were going to stay stable and flat. And once that became apparent, I was able to move ahead with my trip. Also had to consider the implications for my family. I have 3 children and a wife, so I did not want to put them at risk, or, obviously certain factors there had to be considered as well. But all the logistics worked out, and I got assigned to NYU, or New York University, and they have several campuses, but they have a campus called the Langone campus, which is right in Manhattan. So they got me trained up really quickly, and were able to get a set up very, very easily through them. So I'm going to be very candid, as I have been, as I shared about this. I had a lot of anxiety about going up there. I felt that it was the right thing to do, but keep in mind, this was late April, early May. So there were a lot more uncertainties at that point. We still have, obviously, a lot of uncertainties about this virus, but there were a lot more uncertainties in April and even May than we have now. So, I didn't know exactly what I was getting myself into. Am I going to get infected? Obviously was my biggest concern, or what will things be like? And then I tore my knee cartilage about 5 days before I was supposed to go, adding to my my anxiety. But that turned out to not be too big of a hindrance, which, you know, obviously, like I said, it didn't help my anxiety level. Once I got there, as you can imagine, you know, New York had a completely different feel about it than Richmond did. We were all nervous here, but in New York, my first couple of days there in the hospital, you know, you're just wondering, is everything that I'm touching, you know, covered in coronavirus? Now, obviously, that's not the case. I'm exaggerating, but you just had a different sense about your environment and the prevalence of the virus there than I did in Virginia. Just a couple things of interest. So they put us up in a hotel near the hospital. The hotel was 100% full with all medical workers working in COVID. So these were, you know, travel nurses coming from all over the country, other doctors. So even the hotel did not feel safe because everybody else in the hotel was a healthcare professional working directly with COVID patients. So obviously you did not want room service, you did not want housekeeping, you wanted nobody coming into your room. And I put this picture here because each night, you know, I would come back to my room, take off my shoes, and this is a tiny little Manhattan hotel room, stand in the corner, you know, wipe everything down, get straight in the shower, you know, take a shower and kind of essentially decontaminate before I stepped into the rest of my hotel room. I put pictures here of the traffic because this was pretty amazing driving up I-95 from Richmond through Baltimore, Philly, New Jersey Turnpike, New York City back in April and May. The highway was desolate, so it's probably the only time you'll ever see I-95 looking so empty. So I guess that's one of the few benefits of the pandemic is the traffic on I-95 is a lot better than it normally is. The hospital there was quite nice. I worked in this new building that was a 375 bed building. It was only 2 years old, and they were very fortunate when they built it. They built all of the rooms are what are called negative pressure rooms, which means the air is evacuated out of the room directly without contaminating the rest of that area of the hospital. So this is where COVID patients have to be kept. So NYU had had a huge number of cases. They converted many regular nursing units into ICU. So I have to say they had a beautiful view from our ICU. So a little selfishly there, we had a beautiful view of the East River and the Empire State Building. So the ICU where I worked was called the Ventilator Care Unit. It was about 36 beds. And keep in mind, this was just one of many ICUs that they created on the fly. So when I was there, this one facility was down to around 100 ICU COVID patients. They had been up as many as 200 to 300 intensive care unit. And that's not everyone in the hospital. That's just intensive care unit patients in one building. And the week I was there in early May, they had just discharged, one facility had discharged their 1,000th COVID patient, and the other one had discharged in Brooklyn campus their 850th patient. So they were already at about 2,000 inpatients already at the end of April. And they had to create basically a dozen or so intensive care units in this building that did not previously exist. And they had to create them literally in the span of a week or two. So it was pretty remarkable. The fourth year medical students, or the M4s, as we say, they graduated them early just to basically get them done with their process and essentially out of the way. They trained general medicine doctors to be ICU doctors. Their pulmonary fellows in training were escalated to higher levels of ranking. they pulled healthcare workers from all over the hospital who normally would have nothing to do with intensive care unit medicine to work in intensive care, and tried to train them as quickly as possible. So you can imagine, maybe you're a nurse practitioner working in urology or somewhere else. The next thing you know, you're working in an intensive care unit taking care of coronavirus patients. So it happened, extremely rapidly. There were a lot of travel nurses from all over the country, because they did not have enough ICU nurses or ICU trained nurses to take care of all these patients. And obviously the burnout, the fatigue factor for all of these nurses was very, very high. So it was essential that they pull in staffing from all over the country. I won't go into the detail here, but they basically had to restructure everything they were doing. So like I mentioned, we had, a typical team, a healthcare team in the ICU would have, one attending, one pulmonologist. You might have a fellow in training, some nurse practitioners, and like I said, some of the nurse practitioners I'll just skip over because there were a lot of new jobs created, as you can imagine. Night shift doctors, all kinds of new positions had to be created and filled very rapidly. But I remember one morning we were starting rounds, and the nurse practitioner came up to me, and she had just started in the ICU. She said, "I just want to let you know, I've never worked with any patients on respirators or ventilators before." Well, of course, every single patient we had was on a respirator. So, people just did the best they could, and they learned as quickly as they could, and people did what need to be done in the setting of a pandemic. I showed this picture only because this is the picture. This is actually the door on an intensive care unit. So what they did was they wrote down on the door everything that you needed to know about this patient. And it's got their ventilator settings, their medications, their labs for the day, and then the plan for the day. So when we walked by each room, everything was already kind of written. The notes were updated literally on the door of the room. So it was a nice, fast way for everyone to look at all the information about this patient and very quickly, synthesize everything together and kind of figure out what we need to do for that particular day, where everyone could look at all of the data at once. This was a big concern. How many healthcare workers were getting sick from COVID? And up there in New York, it was actually quite a few. I don't have the specific numbers, but just anecdotally, I couldn't help but ask a lot of the folks I was working with, how that had gone. And there were quite a few people that told me they had been infected. And this was mainly a problem earlier on, like in March, when people were still figuring out what was going on, and we didn't have testing for everybody, and we weren't wearing masks, and healthcare workers weren't wearing masks for every patient. So, they had quite a few patients quite a few doctors and nurses and others that did acquire the virus. Even here at VCU, we've had a fair number of healthcare workers get coronavirus. Unfortunately, no one has gotten severely ill. Most of them have been fairly mild illnesses, but it is a reality, and it's a very legitimate occupational risk right now. Two of their facilities at NYU, one of their hospitals in Brooklyn, and then some of you may have heard of Bellevue Hospital. It's kind of a legendary hospital in New York. It's a big public inner city hospital. It was the first public hospital in the United States. I think they have that claim to fame, but these were places that got hit extremely hard. So it was amazing to hear the stories from a couple of the doctors I met who were in those two hospitals during the peak of the pandemic. They described to me literally admitting 20 patients a night to the intensive care unit, just rolling in the door faster than they could even get to them. 20 patients a night. Imagine that. They also told me this unbelievable story of, in one of their hospitals, in the middle of the night, they had 80 patients on respirators, and the oxygen ran out for the whole hospital. So they were scrambling, trying to figure out what happened and get an emergency supply in, and adjusting ventilators, literally running from room to room, trying to save folks. And it turned out it was an actual problem with the oxygen system and line, not the supply tank. So they were able to get it fixed within a couple hours. But just, chaos and crazy story after crazy story of what it was like being there during the peak time. One really fantastic program that they invented, and many of you have probably experienced this if you've had loved ones in the hospital or nursing homes in the last 4 months, no one can go visit these people. So we've had this terrible scenario of many patients in the hospital, even patients, critically ill on death's door in the ICU, and no family member can come visit them. So they created this great program called Family Connect, where the doctors and medical students who did not have anything to do, so, the dermatologists, the ear, nose, and throat doctors, the orthopedic surgeons, the doctors who literally had nothing to do because they weren't operating, took on this role, and they would pair them up with a group of patients, and they would learn and study those patients, and they would call the family members every single day. Even if the patient was in the ICU for 6 weeks, they would call the family members every day for 6 weeks, and have a ability to have a long conversation with them on the phone, update them about their families, their loved one's condition. And really it was a great service because the ICU doctors were just too busy, to have to call every single patient that they had every day. So this was really a great option for those families who were essentially, locked out for their own safety. I threw in a couple pictures of Manhattan just because it was very surreal to see the city so desolate. This is Park Avenue here. With, this is rush hour. You can see maybe 3 or 4 cars there. It was very bizarre to walk around the city and just see a few people out and about, maybe going to get food or something like that, or those that still had to go to work. I have to say, I learned some fascinating scenarios that the pandemic created from a social situation. So a couple doctors were describing to me literally being offered bribes to make sure their loved one would get the necessary supplies, because people in the community were hearing stories that, there weren't enough ventilators or there weren't enough medical supplies. So it seems far-fetched, but this was actually happening, that people were offering doctors bribes to make sure their family member got a ventilator or whatever it was they needed. One other thing that was interesting about NYU specifically is there's a very large Orthodox Jewish population in the NYU region, and you all may have seen in the news this the Orthodox Jewish population got a lot of media early on because they were particularly hard hit by the virus based on where they live, and they live in very close-knit communities. So they were very devastated by the COVID-19 pandemic. One of the other things that I did not know myself until I was working there in New York. The discussions regarding end-of-life care and do not resuscitate discussions, or even taking people off of life support are have very specific views in the Orthodox Jewish community, and there is it's very uncommon for those patients and their family members to make those decisions. So there were a lot of patients in our ICU I worked who were Orthodox Jewish patients who were in pretty bad shape, been on the ventilator for many, many weeks, without a lot of options in terms of where they could go at that point. So it was just sort of another complicating issue in terms of options for a lot of these patients. You all obviously hear in the news a lot of things about the effects of coronavirus, and mainly on the lungs we talk about, and coughing, shortness of breath, pneumonia, respiratory failure to the point of being on a ventilator. Well, the two other things that you'll hear about with this virus that make it a little bit unique are lots of strange effects on the brain, and then also blood clotting disorders. So I know I have a lot of medical jargon here, but that's a picture of a brain MRI with some little small white areas of bleeding. But these folks get a lot of weird things in the brain that we just really don't understand very well. Now, a lot of it is bleeding related. They get strokes. They get small areas of hemorrhage or bleeding, but then they get unusual types of inflammation in the brain, what we call encephalitis or other areas of inflammation. And it's not well understood, but it just seems that the virus, has the propensity to involve the brain tissue as well. And a lot of the patients that I had in my ICU who had been sick for 2 or 3 weeks had pretty devastating brain injuries, unfortunately, to the point where many of them probably were not going to recover from that. Thrombosis or blood clotting. This was also very, very common. And this also makes this virus a little bit unique compared to some of the other ones. These people form blood clots. So this is just a list of some of the things I saw in the patients I had there. So the CVA, that's a stroke. So these are blood clot strokes. Deep DVT or deep vein thrombosis, so blood clots in various veins around the body. Arterial thrombosis, so large arteries in the body clotting off. Heart attacks, so by blood clots. So all kinds of ways that people were forming blood clots as a result of this illness. I know this is probably too small to read, but this was basically an algorithm early on they used in their emergency room there. So basically what it says is if you were a fairly healthy person and you arrived to the emergency room at NYU and you tested positive for coronavirus, but you were otherwise perfectly fine and able to go home, they were so worried about blood clotting, even in a young, healthy person who looked great and was able to go home, they were starting those folks on prescription blood thinners. That's how aggressive they were being, because they were seeing so much in the way of blood clotting disorders. Now, that didn't continue exactly that aggressively, and folks have modified that approach, but it's still very much a concern about how high the risk is for blood clots in these folks. Pulmonary toilet, that's a term that's not actually a toilet, but that's one of our favorite terms we use in pulmonary medicine to describe the issues with mucus and cleaning out the airways. So this seemed to be a really big problem for patients with coronavirus. especially on the ventilator. So these folks generated lots of mucus, and they seemed to be plugging their airways and plugging their breathing tubes on a regular basis. So they were very aggressive about humidifying these patients. They did a lot of suctioning in these patients. Some of you are familiar with the pulmonary vest that you can wear that does chest percussion to try to loosen secretions. They did a lot of that. They did a lot of nebulizer therapy with saline or mucomist and other things, and even did a lot of tracheostomies in these patients because they were having so many issues with mucus plugging. So this was a really big issue for them, and they tried to be very, very aggressive in treating these patients for their mucus and airway issues. Mechanical ventilation. So you heard a lot in the news about ventilators, about, oh, it's bad to put these people on a ventilator. We're going to have ventilator shortages. Fortunately, we did not end up, even in New York, did not end up really with a severe ventilator shortage problem. But it was an issue. They had to use a lot of older ventilators. This is a picture on the right of an older ventilator that really doesn't get used anymore, but they used a ton of them there at NYU because it's all they could get for their ICUs for a while. A lot of these patients had to undergo tracheostomy, putting their breathing tube in the neck because they had been on the ventilator for 2, 3, 4 weeks and not making any progress. We had to develop a special technique and how to do that safely because everyone's worried. Obviously, if a patient has coronavirus, the last thing we want to be doing is going down into their airway with cameras or instruments where we might create, coughing or aerosolization of the particles. So everything we did had to be modified and adapted to patients with this virus. I was reassured by the fact that at the time, again, keep in mind, this was late April, early May, and all the drug therapies were very much evolving rapidly. What I saw there, fortunately, was essentially the same things we were doing back here in Richmond. We were using the same drugs. We had the same research, clinical trials ongoing, and the same medications for the most part. So, I felt good that we weren't missing out on anything that was being done there at a higher volume. Patients were still getting the hydroxychloroquine or Plaquenil back then. As you may have heard, that has faded out of practice somewhat. Remdesivir is another antiviral drug that was being used and actually is still being used. And then giving plasma of patients who had the infection already to patients who now have the infection. They were doing that as well, just like we have offered here at VCU. And then I won't go through this list, but a whole list of new drugs and old drugs that are in various stages of research trials being rapidly done to try to get us some other options very quickly. I want to take a minute too and just talk about this whole notion of how the virus is spread, because we're starting to see more interest in this, more news stories on this, more debate. So the old concept and the concept from the beginning of coronavirus is that the virus is spread by what are called droplets. Droplets are larger particles that come out of your nose or your mouth. So these are, particles of secretions, mucus, saliva that in theory would contain the virus. But these are larger particles that if you breathe or cough or sneeze, they don't go very far because they're heavy. They quickly settle, on your desk, on your carpet, on your sofa, on your table, wherever, someplace very close to you. So they don't travel more than 2, 3, 4 feet. Because the whole operating thought of coronavirus is that it has predominantly been spread by droplets, that's where the whole 6 feet idea comes from, because these particles don't travel very far. Now, obviously, if someone coughs a droplet onto a table, then someone would have to wipe that table with their hand, make contact, and then, put their hand in or around their nose or their mouth to spread the disease. Aerosols are smaller particles. So aerosols are much, much smaller particles of mucus, saliva, secretions when you cough, sneeze, breathe heavily, that can come out. And as a result of them being much smaller, much lighter, they travel further. If you cough or sneeze, aerosols can go, 20 feet, 25 feet. And then they can hang around in the air a little bit longer. They're not heavy. They don't immediately fall to the ground, onto a surface. So now we're starting to see a little bit more debate about, well, maybe coronavirus can also be spread with aerosol particles, these smaller particles. So the bottom line is we don't know for sure. We still think that droplet spread is the most common way this is done, but there's starting to be more thought and more research into aerosol spread. And keep in mind, a lot of this is based on other viruses, flu virus or RSV or multiple other types of coronaviruses over the years. So why does it matter? Well, that it does make a difference. I mean, the regular masks that we're all wearing, the cloth masks that you wear, the regular surgical masks, are probably pretty good against droplets, both in keeping them from going into your respiratory system or also keeping them from leaving your system and going out if you're wearing a mask and you cough. The regular masks are probably not as good at protecting people from aerosols. The higher level masks, the N95 masks that we wear, in various scenarios in the hospital, or the P100, these higher level masks, those are pretty good at aerosols. But obviously that's not what we're doing as a culture. We're wearing regular masks. So as we get further into this, if we find out, through more research and study that aerosols are maybe more common way of spreading this virus than we realize, we might have to rethink, the type of masks that we're using. Now, I'm not saying that to scare you all or scare anybody that we're wearing the wrong types of masks. I think, we're doing the right thing by masking, but it just goes to show you it's still a big uncertainty about how this virus is spread. Here's a couple of pictures of Times Square. You see nobody out there, so pretty amazing to see that sitting empty. One other thing that I found fascinating about this virus is this is, I guess, good or bad, all of us, but those of us in healthcare and healthcare education have gotten to experience the single largest creation of medical literature on one disease in the history of time, or the history of medicine. So never before has there been a single disease which generated more research articles, more publications, in the medical literature and in the non-medical literature and social media than ever before. So PubMed is the main medical database that we use. So if you search for coronavirus or COVID-19, you can see in 2020, there are 32,000 articles published in our main medical journals in 2020. And keep in mind, that's not in a year, that's in 5 months that happened, basically from, January to June, or February to June. we had 32,000 publications on COVID-19. So trying to keep up with that, trying to police the quality of those publications. As you saw in the news, some of these things turned out to be bogus. Some of the quality, even in some of the big name journals, turned out to be based on bad data. So it's been a real challenge. We have to balance, there's an overwhelming need to disseminate information rapidly around the globe, but there's also that balance of needing to disseminate good information and not compromise quality, you know, by a speedy effort. So we've seen that happen even in the New England Journal of Medicine and the Lancet. Those are the two of the top most reputable medical publications, and both of them fell victim to large studies about hydroxychloroquine and Plaquenil, which turned out to be based probably on some questionable data, or not necessarily falsified data, but not solid data. So again, it's been very challenging to try to, you know, perform research at a faster than normal pace and create information that'll be useful without compromising quality and patient safety, obviously. I found this, a friend shared this article with me, and I thought it was just a neat context. This was a little short essay written by C.S. Lewis, of course, who wrote the Chronicles of Narnia. And it was the topic on what it was like to live in an atomic age during the 1940s. And it was an interesting, if you read the article and replaced the term atomic age with, you know, or atomic bomb with coronavirus, everything fit very, very well. But I love the quote where, you know, for a lot of us in my generation, we feel like we're living in some never faced, you know, scenario before by mankind. And, you know, the C.S. Lewis quote here said, "Do not let us begin by exaggerating the novelty of our situation. Sure, we haven't seen coronavirus before, but man has faced many other pandemics and plagues, and the fear of living under other scenarios, as I'm sure many of you can attest to better than I have, whether it was polio, you know, in the 1950s, and the fears, you know, you may have had as in childhood then. But that picture there is just a picture of the iron lungs back in the 1950s from the polio pandemic that obviously also created tremendous fear amongst everyone in our country and around the world. But I always liked the kind of concept. It gave me a little bit of peace that while coronavirus is new to our culture and seems overwhelming, it's not by any means man's first rodeo with this type of pandemic or challenging situation. All of our conferences, all of our medical education, our big national meetings, everything has gone virtual this year. So, you know, these are all of our major medical meetings that we're going to have, or already starting to have this fall. American Thoracic Society and all of our other meetings are all going to be online. So these are meetings that normally would have 5,000 to 15,000 people in attendance. So you can see how it's affecting, you know, things like that, even from a medical education standpoint as well. I wanted to share just a little bit about coming home. I was only there for about a week because that's all I could really do in terms of my responsibilities back here at VCU. So when I was coming home, I wanted to get a COVID test, not because I was worried that I had it, but more for the peace of mind for my family. So I did that, and then I stayed. The health system here was putting employees up in a hotel if we wanted to shelter away from our family. So I did that for a few nights and got my COVID test back, which was negative, and then went home and stayed in the guest room for just a few more nights. I'll take that scenario just to point out, of course, you know, what you hear all of us talking about is this 14-day window that if you get exposed to the virus, that it may take up to 14 days for you to actually get sick or show symptoms. That is true, but keep in mind that's a sort of an extreme to make sure that we don't miss anything. The majority of people who are exposed to the virus who then get sick start showing symptoms around day 5 or so, day 5 or 6. So that's the vast majority of people. Yes, there are uncommon or rare cases where people don't get sick until day 12, day 13, day 14, but that is the extreme. So when we say 14 days, again, that's erring on the side of caution. So if you get exposed to someone with the virus and you get it, more likely than not, by, you know, the 4th, 5th, 6th day, you're going to have symptoms at that point. So, but we do use that 14-day range just as a real extreme precaution. So that was just a picture out of the window there where you can see the words "thank you" that a neighboring building had put in their windows for to send a message to the healthcare workers at NYU. So I'm going to stop there and let me know if you all have any questions.
Okay, I've gone and unmuted everyone.
I have a question. It's Smokey Cruz. Can you hear me?
Yes.
Hey, Dr. Shepherd, good to see you again, and thank you for what you're doing here and helping the folks in New York. My question concerns hydroxychloroquine. Would you speak about that, please? There seems to be a lot of debate about that.
There sure is, and it may go on for a while. So obviously early on in the disease, this drug immediately became, you know, the most popularly discussed medication as a treatment option. And I think that happened for a couple of reasons, just theoretical reasons about the drug, but also because it's an old drug, been around for a while, people could get it. And then the pendulum kind of swung back as we started getting more and more data that maybe hydroxychloroquine was in the early studies that were done, was not showing as much benefit as people had hoped. So what happened then, probably by the time you got into May and June, already the drug had started to fall out of favor. So I would say right now, you know, at most centers that are treating coronavirus, most folks are really not using hydroxychloroquine very much at this point. It's not to say that some people won't get it, and you'll still hear on occasion some providers, you know, offering it to patients. But here, I know right now at VCU, it's not something that we're really using. We're using remdesivir, we're using steroids, we're using a couple other things. But hydroxychloroquine, at least for the moment, has fallen somewhat out of favor. But, you know, I will say about all of these medications, the way things sometimes happen in medicine, you know, we're doing a lot of studies very rapidly, and we don't know where we'll be, you know, a year from now or 2 years from now. It is entirely possible, I hope I'm wrong, but it's entirely possible that a year from now, we may have larger studies that are better done that show none of these medications help. I hope I'm wrong, but I just know how things often go in healthcare and drug studies. So hopefully, you know, we'll continue to identify some drugs that truly have benefit. Obviously, a vaccine being the first and foremost one, but so yeah, hydroxychloroquine, popular at first, now fallen out of favor a little bit.
All right,
I have
thank you.
about the post-care in the ICU. Was there a special area, a special unit, let's say a step-down area that these patients that would have a favorable course ICU are transferred to? And how is their care different since they're not on the ventilator?
Yeah. So, and were you asking about NYU specifically or here?
NYU.
Yeah. So they had, you know, a couple pathways. If folks in the intensive care unit improved significantly to the point they could go to like a general floor, then of course they would do that. They would still have to be in the negative pressure rooms that I described to you with, you know, all the precautions, respiratory precautions for staff and everybody. And, you know, at that point, every patient, even if they'd been in the hospital for 6 weeks, we didn't know how long they were infectious at that point. So we didn't know if they could still spread the virus even after 4 weeks or 6 weeks. I think now we have a better sense that, you know, at 4 weeks or 6 weeks, you're very, very unlikely to be contagious. But those folks were all kept on strict respiratory precautions. Anything that we would consider generating aerosols, those particles I was talking about. So if patient was getting a nebulizer, was on high flow oxygen, if the patient was getting suction, all of those things, as minor as they are considered high risk to healthcare work. So all of those things, you still have to maintain strict precaution with N95 masks, you know, goggles, face shield, gowns, gloves. So, you know, those patients were still followed. The patients that did not get rapidly better in the ICU were transferred to an ICU like the one I worked in, where they were on the ventilator for many more days, sometimes many more weeks, unfortunately, you know, trying to slowly be weaned off the ventilator. And a lot of those patients had pretty bad brain injuries too, unfortunately, which was very sad to see. So a lot of those folks may not get better from a neurological standpoint.
Thank you.
I wanted to know if treatment was different for someone with obstructive disease versus restrictive. Some of us have pulmonary fibrosis, and some of us have asthma or COPD, and I'm afraid to get on a ventilator having a restrictive disease. What is the treatment for that, and do people get better that have that?
Yeah. Well, I mean, any underlying respiratory disease is a concern that you've heard about from the beginning. And, you know, that's not unique to coronavirus. I mean, any bad pneumonia, whether it's a virus or a bacteria, you know, common pneumonias, obviously if someone has underlying or pre-existing lung disease, they're going to have higher risk of getting sicker. But back to your questions about restrictive lung disease, obstructive lung disease. I mean, from a treatment standpoint, you know, medications are going to be the same. The drugs we use to treat folks are going to be the same. The things that might differ would be, you know, what type of mechanical ventilation that's being done. A lot of people early on in the news, you saw some news stories that said, well, it sounds like we're learning that it's really bad to put these patients with coronavirus on a ventilator. So doctors are learning that we should not put these people on a ventilator. Well, I mean, that was a little bit misleading, I thought, because we never want to put anybody on a ventilator. So our goal is always to not put someone on a ventilator. So if there's somebody with coronavirus who ended up on a ventilator, it's only because it was the last resort thing we could do, and all the other options weren't working. So, you know, and once the patient's on a ventilator, you know, we're going to have to use whatever techniques are available. But I mean, to your question, really, the type of lung disease may have some implication in how we set up the ventilator, as you know. But otherwise, the treatments are going to be pretty similar.
Okay.
Doctor, this is Billy Williams. I have a couple of questions. I had to move away from the screen here for a few minutes to somebody knocked on the door. But our first question would be, I've had lung cancer, had a lung removed. Do I still get the same kind of treatments as everybody else? And question number two has to do with the test. I did have a test, and they told me it was 70% accurate. What do we know about those tests today?
Yeah, good question. So, you know, having had a lung or a lobe of a lung, part of a lung removed, would not change, you know, anything in terms of treatment if a patient had the virus. But it certainly does put a patient into a higher risk category. So again, a patient with existing lung disease or any type of compromise is going to have to be more careful, more vigilant about masking, you know, self-isolating, social distancing. And I know those things are very hard to do, there's no doubt. And we've been doing them for months now, and everyone's very tired of it. But, you know, it is still the right thing to do. If you're a high-risk patient, you have to stay very vigilant about those things. The testing question, that's obviously a complicated one, but, you know, there are now numerous tests out there on the market, and some of their different types of tests, they use different genetic techniques, rapid tests. There's tests that come back very quickly. If you go to Better Med today, you can get a test back in 15 minutes. That's an extremely rapid test. It's not quite as good, though. It's not quite as sensitive as some of the other tests that take a day or two to come back. So, you know, there are a variety of tests available depending on what the scenario is. So some of them are better than others. I know now, just recently, there's been discussion about another test coming that's going to be, or it's already exists, but that's an oral swab, a mouth swab instead of a nasal swab or a deep nasal swab. So again, this is a moving target. I don't know really anything about the oral or the mouth swab test, and whether or not it's going to be as good as the other one. I don't know if any of you all have had the nasal pharyngeal or the deep nasal swab test for COVID virus. It's not fun. It's pretty uncomfortable. So I've had 2 of them so far. I'm not looking forward to my 3rd one, but anyway, I'm hoping we'll get some little bit easier testing options. So, but there's just many out there, and I mean, overall they're good, but they're not perfect. You may have heard cases of someone who, you know, tested positive with one of the tests that's less accurate, so then they went and got, you know, one of the more definitive tests, and it was negative. So, you know, I've seen that happen to patients as well.
Thank you.
This is Joan Stoller. I have a question about the plasma.
Yeah.
My husband had a fairly mild case of COVID back the beginning of April. and he's donated plasma now 3 times.
Huh?
And he can do it every 28 days, so he's set up to do it every month. How does that help the patients? Is it a blood transfusion that they get?
Yeah, they basically get, it's essentially like getting a blood transfusion. So they take, the donated plasma, and in theory, the plasma of someone who already had the virus contains antibodies to the virus. But there's a couple of things that we don't know that are still evolving now. And in your case, I don't know, the logistics, but there's so many things about the antibodies and the plasma that we don't know for sure. So, for example, we don't know how long antibodies last. So, if I had coronavirus in March, do I still have antibodies today? I don't know unless I go get an antibody test and see. Just because you have antibodies, do we know for sure that that protects you from getting, the virus again? Well, it should in theory, but again, we don't have proof of that.
Right.
One indirect proof is we really don't see people, we really haven't seen patients getting the virus a second time. People really haven't described that occurring. So that's a good sign. And then the other thing is, and I don't know, in your husband's case, did they test his antibody to see if he had antibodies before he donated plasma?
Yeah. Yes, they did. He
Yes.
goes to the Red Cross and they do an they did it. He donated again last week, and they did an antibody test.
Yeah,
And
because
they said he is still having antibodies.
Okay.
He's also gotten a couple of emails saying that his plasma, the first one said his plasma helped several patients at Chippenham Hospital.
Yeah.
And then he got another email a few weeks after the first one and said that his plasma went to Southern Virginia, I think,
Yeah.
somewhere in the Lynchburg or Roanoke area. So
That's,
he is getting follow-up as to where his plasma is going.
yeah, that's great. Because when we first started giving plasma, we weren't even testing the patients who were donating. We couldn't even really test to see if they had antibodies. We were literally giving plasma from people who had the virus, not even knowing
Not knowing.
if they had antibodies or what level of antibodies. So at least now we can confirm that there are antibodies in those patients that are donating plasma. So
Well, they have done the antibody test on him at least twice. And this last time he actually did a double unit. They took out more and were able to do that. Took a little bit longer, but he for one is going to donate as often as he can, which they say is every 28 days.
Right. And then the interesting thing will be, and only time will tell, these patients who had the virus, it's very fascinating to see in the next 12 months if their antibodies are still there.
That will be interesting.
Antibodies are still there a year from now or 2 years from now. That's what we want to see. That's what
Right.
we hope, that this will be a sustained immune response with sustained immunity down the road.
Okay. Thank you very much.
This is a quiet group. They're normally not quiet.
Well, I've got a question.
Ask.
Can I ask a question?
Of course, Keith, go ahead.
Are we limited to questions about the subject matter? Or can I ask the doctor about another respiratory matter?
I'll let him answer.
I'll do my best.
I guess I'll just do real bullet points to get to the point. May 2016, I had a colectomy, ended up with sepsis, septic shock, ICU for 30 days. October that year, I had a lower left lobectomy because of the sepsis. Then January this year, diagnosed with emphysema, and June, diagnosed with pulmonary fibrosis. I've been reading a couple things about a Zephyr valve. I was wondering if you could touch on that.
Yeah, no, that's your question is very right before I came on this call. We just put some valves in a patient. So the valves are actually specifically for emphysema COPD, not for pulmonary fibrosis. So they're little one-way valves that go in part of the lung in patients with severe emphysema. So it's a very specialized group of patients with emphysema that are candidates to get these valves. So they have to have a lot of specialized testing ahead of time. But no, they don't have any role in pulmonary fibrosis.
Okay.
But they are an uncommonly used treatment for people with a specific type of severe emphysema.
I've got an appointment with one of your colleagues next week, Dr. Grinnan.
Uh-huh.
Yeah, so it's a second opinion I really want because I just don't think I'm getting any better.
Gotcha. Well, you'll be in great hands.
Yeah, I read about him. He just seems top notch, A1 there. Okay. Thanks for answering that, though. Appreciate it.
Dr. Shepherd,
Yes.
what are some of the symptoms that people are having after it's all over, after their 14, 15-day period?
Yeah, it's been interesting. I guess, if people, well, obviously it depends on how severe their illness was, but obviously those who are hospitalized with respiratory failure have a much longer recovery. People who were able to manage the infection at home, even some of those people are describing longer recovery periods of 2, 3, 4 weeks before they really feel normal again. Even still some lingering shortness of breath or just lingering fatigue. So it does seem in some cases to have a little longer recovery than a lot of other viruses that we deal with. But nothing real specific. I think the main thing people still worry about is monitoring for any blood clots or other complications those first couple weeks, since that seems to be such a common side effect.
So they do get better, back to normal, they're normal.
Well, as best for people who were not sick enough to be in the hospital, I think so. I think time will tell for people who had COVID and COVID with pneumonia or COVID respiratory failure on ventilator, high levels of oxygen support. I think those folks, will have to be followed over the next few months and retested and evaluated to see if their lung function, recovers fully back to normal.
Okay. Thank you.
Sure.
Once you have a positive COVID test and it turns negative, are you able to lift all restrictions, or is there some period that you still follow restrictions with?
Yeah, most of the guidelines in terms of relaxing, social or relaxing isolation or quarantine are based more on symptoms and time from the first positive test. So, people who test positive are not required to have necessarily, to have a negative COVID test to relax their quarantine. So usually, depending on the situation, if you test positive, it's usually quarantining 10 to 14 days from the last symptom or last fever, depending on the circumstances. So because the other thing we've learned is, and I saw this at NYU quite a bit, we had a number of patients who were 4 weeks out from, or 5 weeks out from when they tested positive, and they still were testing positive on the repeat test. Now, that doesn't mean they still have the disease and are infectious. It probably means that the test was so good that it's still detecting, you know, pieces of virus or non-infectious virus in their secretions. So just because, you know, most people, if you tested positive today and you were sick and you went and got another test in another week, you might still test positive, even though you may feel completely back, you know, back to normal. So the testing, follow-up testing is still a little tricky. That's why, you know, you don't have to have a negative test to lift the restrictions, you know, from quarantining at home.
Thank you.
Or going back to school for kids, you know, for example.
There's a lot of talk about a second wave. Is this virus mutating, or is there any indication that it's mutating into something else?
Yeah, I'm certainly not an expert on the virus, but from an infectious disease standpoint, I don't think we've really seen much about that at this point, and that certainly can happen with any organism. I don't, to my knowledge, I don't think it's been a real issue so far. You know, I don't know if you've read anything, you know, from a history standpoint. That was the big issue with the Spanish flu in World War I. It came and mutated and then got redisseminated around the globe. But, you know, that's a big, the mutational ability is a concern, you know, as far as a vaccine goes, because if we're making a vaccine based on the current virus, and 6 months from now it undergoes a significant mutation, then your vaccine is going to be less effective. So, but to my knowledge so far, I don't think we've really seen a lot of evidence of that, but it's still, you know, it's still very early in the process. We're still only 6 months really into this thing.
Thank you.
Yeah. And I'm probably, I hate to cut people off, but I'm probably going to have to head out here in just a minute off the call, if that's okay with everybody.
Is there one last question? Dr. Shepherd, if you could very quickly tell us, we've got the flu season that's coming up. How, as a consumer, are we able to best tell the difference between the flu and the virus?
Yeah, that's a great question. You know, and the same issue is going to come up even with the common cold, because you look at situations where there are schools that are going back in person, you know, and a lot of these schools are saying, well, if your child has, you know, a cough, a runny nose, and a fever, they need to stay home and quarantine 14 days in case it's the coronavirus. Well, it may just be a cold because everyone gets colds. So the flu, at least, you know, can have a few distinguishing features. It, you know, can be more likely to have the muscle aches with it. But the problem is, to your point, there is still so much overlap between, you know, flu, common cold, and coronavirus can all have cough, congestion, fever, you know, very non-specific respiratory symptoms. So it is very difficult and will be very difficult to distinguish it. And the other tricky part with coronavirus, as you've seen, is people can have anywhere from no symptoms at all to, you know, deadly symptoms. At least with flu, most people with flu have some symptoms of some kind. Most people with flu have pretty clear-cut symptoms. There aren't a lot of people with flu walking around who have no symptoms at all. Whereas coronavirus, it seems to be the more we test, the more we figure out there are people who have it and never had any symptoms. So, but it's going to be very hard. I think, you know, that maybe the muscle aches, the myalgias, are one thing that might help distinguish, but I just think it's going to result. I think we'll probably see more people getting flu tested, you know, because they're trying to make that distinction. Do they have flu? Do they have coronavirus? So I have a feeling this fall and winter we'll see, you know, obviously we'll see a lot of coronavirus testing going on. And we'll probably see more people getting, you know, flu tests too, just trying to make the distinction. You know, people come into your doctor with those symptoms. I don't know, you may get a flu swab and a coronavirus swab, you know, at the same time, just to try to sort that out. So it's going to be a challenge. It's going to be a big challenge.
Thank you, Dr. Shepherd. Thank you so much for your time.
Right.
We're so grateful, and thanks for all that you do to graciously help people. We appreciate you.
My pleasure. Thank you all for having me again.
Thank you very much.
Yeah.
All right, bye-bye.
Good day.